Mm, Hello, can you hear me? Uh, Good morning. My name is Dr. Mazin Ahmed Tijani. I'm BBS University of Khartoum Faculty of Medicine, pediatric registrar in the second year of training. Mm, I'm doing molecular medicine master, uh, molecular medicine student mm, at the University of Khartoum Institute of Endemic Disease. Uh, Today I will present to you Down syndrome trisomy 21. I think this presentation is for postgraduate level, but it can work for final 6 year medical students. I think it can work for them also. Let us start the presentation. Down syndrome, or what is called trisomy 21, is the most common autosomal trisomy and the most common genetic cause of severe learning difficulties. The incidence of Down syndrome without antenatal screening in live birth infants is about 1 in 650. Very common. Parents have normal karyotype. About 95% have three freestanding copies of chromosome 21. Approximately 1% of individuals are mosaic with some normal cells. Approximately 4% of Down syndrome individuals have a translocation involving chromosome 21. Maternal age has a strong influence. Less than you can see here the incidence in less than 20 years who mothers is 1 in 1550 live births, and in more than 45 years it is 1 in 25 live births. Very dramatic, very uh, very huge difference. Clinical features: Down syndrome is usually suspected at birth. That is why any child should any child delivered at any place should be attended by a neonatologist. That is not applied in low socioeconomic status countries like Sudan. Anyway, because of the baby facial appearance, most affected infants are hypotonic and other useful clinical signs. It is useful to give a precise long-term prognosis in the neonatal period, as there is individual variation in the degree of learning difficulties and the development of complications. Over 85% of infants with trisomy 21, or what we call Down syndrome, survive to 1 year of age. Congenital heart disease is present in 30%, and particularly atrioventricular canal defect is a major cause of early mortality. At least 50% of affected individuals live longer than 50 years. Counseling may be helpful to assist the family to deal with the feeling of grief, anger, or guilt. Okay. Typical craniofacial appearance of a patient or a baby with Down syndrome: round face and flat nasal bridge, abslented palpebral fissures, epicanthal folds, a fold of skin running across the inner edge of the palpebral fissure. You can check for pictures with babies with Down syndrome to see this specific appearance. Brush filled spots in the iris, pigmented spots, small mouth, and protruding tongue. As part of the generalized hypotonia, I think. Small ears, flat occiput, and serrate fontanelle. Other anomalies: short neck, single palmar crease, incurred fifth finger, and wide sandal gap between toes. Hypotonia, congenital heart disease in 40%, duodenal atresia, the bulbable sign, the classical finding in chest in abdominal X-ray. Hirschsprung disease, aganglionosis. We will talk about this complication later. Later medical problems: delayed motor milestones, moderate to severe learning difficulties, small stature, increased susceptibility to infections, hearing impairment from secretory otitis media, visual impairment from cataract, squint, myopia, increased risk of leukemia and solid tumors, risk of atlantoaxial instability. This is very serious. Risk of atlantoaxial instability. What type of leukemia do children with Down syndrome are at increased risk of? Do you know? Should I leave these questions at the end? Think about it. Increased risk of hypothyroidism and celiac disease and epilepsy. Mortality 40% until 10 years. Cardiac complications. Cytogenetics. Do you know what is cytogenetics? The extra chromosome. It is a trisomy, as I mentioned. The extra chromosome 21 may result from meiotic non-disjunction, translocation, or mosaicism. Which one is the most common? Which one? Meiotic non-disjunction accounts for 94% of cases with Down syndrome. In non-disjunction trisomy 21, most cases result from an error at meiosis. The pair of chromosome 21 fails to separate so that one gamete has two chromosomes 21. Fertilization of the gamete with two chromosome 21 gives rise to a zygote with trisomy 21. Parental chromosomes do not need to be examined. I think this is very clear. The incidence of trisomy 21 due to non-disjunction is related to maternal age. This is the most important part in this lecture. This is the most important message. However, as the proportion of pregnancy in older mothers is small, most affected babies are born to younger mothers. I think this is very important. However, as the proportion of pregnancies in older mothers is small, most affected babies are born to younger mothers. Furthermore, meiotic non-disjunction can occur in spermatogenesis, so that the extra 21 chromosome can be of maternal origin. This is very interesting. All pregnant women are now offered screening tests measuring biochemical markers in blood samples and often also knuckle thickening on ultrasound. Uh, Unfortunately, these such things are not done here in Sudan. We are a poor country. We are poor in everything. Thinking of the soft tissues at the back of the neck to identify an increased risk of Down syndrome in the fetus. When an increased risk is identified, amniocentesis is offered to check the fetal karyotype after having one child with trisomy 21 due to non-disjunction. The risk of recurrence of Down syndrome is given as 1 in 200 for mothers under the age of 35, but remains similar to their age-related population risk for those over the age of 35 years. Don't bother yourself with these too much details. Translocation occurs only in 5% of cases. What is translocation? When the extra chromosome 21 is joined onto another chromosome usually chromosome 14, but occasionally chromosome 15, 22, or 21. This is known as Robertsonian translocation. This may be present in a phenotypically normal carrier with 45 chromosomes, two being joined together, or in someone with Down syndrome and a set of 46 chromosomes, but with three copies of chromosome 21 material. In this situation, parental parental chromosomal analysis is recommended. This is the situation where you should test the parents, where you should bring the father and the mother for genetic testing, since one of the parents may well carry the translocation in balanced form. In translocation Down syndrome, the risk of recurrence is 10 to 15% if the mother is the translocation carrier, and about 2.5% if the father is a carrier. I think this is very clear. Mosaicism occurs only in 1%. In mosaicism, some of the cells are normal and some have trisomy 21. This usually arises after the formation of the chromosomally normal zygote by non-disjunction at mitosis, but can arise by later mitotic non-disjunction in a trisomy 21 conception. The phenotype is sometimes milder in Down syndrome mosaicism. Okay, I think this article is very interesting because it remember me by one of our patients at Ja'far ibn Auf teaching children hospital, who was a case of Down syndrome, 7 months old, present complaining of convulsion, repeated attack of convulsions, and the something that what was very interesting is that the stridor, the abnormal sound in this child. So I looked up in the literature to look for what is associated with Down syndrome. I find this article very interesting. Diagnosis and therapy for airway obstruction in children with Down syndrome. So you can check it. You can check it. I can share with you my PowerPoint. This table is very important. Primary and secondary diagnosis for children with Down syndrome presenting with upper airway obstruction. Primary sleep apnea, 11 laryngomalacia, 10 tracheomalacia, 1 inhaled foreign body, 1 ear canal atresia, chronic sinusitis, laryngomalacia, recurrent otitis media, recurrent tonsillitis, vocal cord palsy. I think my patient is in this area, the area of laryngomalacia. Okay. Now he will be seen in by the otolaryng in the ENT department. He will be assessed there. What I want to say is that that is all for today. I think this is a very beautiful picture. This is me. This is me in one of our in one of the villages of Sinnar, a village called Kassab Garbay in Sudan. This is where schistosoma hematobium lives. This is where schistosoma hematobium lives. I think we should do a lot of effort to fight such diseases. That is all for today. Thank you very much. If you have any questions, please leave it leave it in the comments in my YouTube channel. Thank you very much.